Let's face it, we all know that injuries suck. Not only do they impair your ability to enjoy each and every day, but they can also hold back your longevity, your health span, and your body's ability to repair and regenerate. What if there were some solutions that have been around for a long time? I'm talking molecules and substances and therapies that can be quite cheap and also very effective at keeping the body young and working optimally. That's the case. And today, we're joined by a double board certified physician in physical medicine, rehabilitation, and anti aging regenerative medicine. So she specializes in exactly this stuff. Her name is Dr. Elizabeth Yurth, and she has over 30 years of clinical experience and continues to stay at the forefront of orthopedics, cellular medicine, regenerative medicine, and the future of aging. Dr. Yurth is the co founder and chief medical officer at the esteemed Boulder Longevity Institute. She's the co founder and lead educator at Human Optimization Academy. She's a medical advisor at OHP Health and also our guest for this episode. Hi, I'm Nick Urban, the host of the Mind Body Peak Performance podcast. And if this kind of thing interests you, you'll want to check out a previous episode I recorded with Dr. Suzanne Turner, episode number 55. You can access that at mindbodypeak.com/55. And on that one, we also talk a lot about orthopedic injuries and how you can, quote, bulletproof yourself against them and bounce back quickly. For this episode, all of the resources will be in the show notes at mindbodypeak.com/141. And if this show is interesting or helpful to you, I'd appreciate you to go over to wherever you're listening to it, give it a thumbs up, a 5-star rating, or whatever you think it deserves, because that's how I continue bringing you thought-provoking guests like Dr. Elizabeth Yurth. All right, without further ado, let's bring her in. Dr. Yurth, welcome to Mind Body Peak Performance.
Thank you for having me, Nick.
It's great to meet you. And today we are going to discuss all things under the realm of sports medicine, orthopedics, and a whole lot more. But let's start off today with something controversial about your field of expertise.
So I think that's going to have to start you out for you guys to understand a little bit of my history. So I came from a very traditional orthopedic world, which is not a very usual way to get into what we do, right? Most docs come from maybe an internal medicine background or an ER background who's do more of this biohacker or functional medicine. But in orthopedics is probably the bastion of people who are these are guys who just fix things and then everything's fixed and all's better. So I've been doing that practice for literally 30 years. And probably about 18 years ago, I was like, Jesus, all I ever do is kind of patch people up and they never really get better. Like they kind of get better, but they're never cured. Everything still sort of hurts after you fix it. And then that group of people who all you do is watch them kind of deteriorate over time because I was in practice long enough. They had the same patients for years and years and years. They would just kind of keep getting worse and worse and worse over time. And then you replace their joints and then another joint goes and that's sort of the realm of it, right? And so I started to realize there was a lot more that we were missing in orthopedics than just, okay, you have an injury and we fix the injury and then all's well. And so I started to kind of explore how did, health and nutrition and hormones and all the things that are involved in joints actually make a difference in getting people healthy. So I kind of went back. And, this is when this type of medicine was kind of just getting a start 18 years ago, honestly. And, the A4M, which is now a big, huge conference, was like 500 people. And, and so it was really a small group. And so I went back and got my training through A4M, which is the American Academy of Anti-Aging Medicine. And then said, okay, good, I'll just combine this to my orthopedic practice and I'll be able to really help people now. And then I realized that was impossible to do in the insurance world setting because I had 10 minutes. And there was no way I was going to be able to actually tell people everything they need to know. So I went back to kind of going, well, I'll just sort of fix them and send them on their way, or not fix them and send them on their way. But it was really frustrating. So we, 17 years ago, then opened this clinic, Boulder Longevity Institute. And I actually did both practices. So I went to my orthopedic clinic in the morning and I'd come here in the evening and do what I felt was actually real medicine. And I actually would try and get some of the orthopedic patients. I'd say, listen, I can actually really make you better if you come over and see me there. But that's, not insurance based. And so people were like, well, if I'm paid, but people kind of gradually got into it and realized, wow, I am getting better when I go over there and see this piece. And so I started to focus a lot more on that kind of medicine. And then really it wasn't until about 3 years ago now that I actually said, okay, I can't wear both the hats. I feel like I'm doing a disservice to these people all day long. And so I combined the two practices under this roof, Boulder Longevity Institute. We still do a lot of orthopedics, but we really do it in a lot more of a regenerative medicine fashion. And how do we actually take somebody who has injuries and make them so they actually get better? Because we always think, okay, well, you tear your ACL, you fix the ACL, it's all good. And I can tell you from my own experience, I've torn my ACLs 4 times. So avid skier, I tore each of them twice. Didn't even fix them the last time. Actually, I tore one again and didn't even fix it. I was like, screw this isn't working for me. And when you look at ACL injuries, which people will tell you tear your ACL at 18, fix it, all is good. 75% of those people go on to develop arthritis. Really at a young age, by 50 years old, they have arthritis. So we're not doing something right? There's something that's not right. So even if we fix your broken bone or we put back together your torn ligament, you don't go on in most cases. Some people do, but in most cases, people don't go on their merry way and do fine. So I really started to learn what happens in joint injuries and try to actually treat the fact that these joint injuries are actually creating a systemic issue that we need to address from square one. So just like, and that all this arthritis that people are having, right? And everybody's like, oh, I just, and I get this all the time. And you probably hear this too, Nick, oh, well, I played football. So of course my knees are bad. Or I ran, marathon. So of course my hips are bad. So it's really the biggest, most controversial thing. We don't wear out our joints. We don't, if you guys think you use your brain too much and it wears out, or your heart too much and it wears out, it's not the case. And joints are not any different. In fact, great study that came out last year that looked at sedentary people, and the biggest risk factor of getting arthritis was sitting on your couch doing nothing versus the people who were exercising in a very high level of running every day. So what we learned is that osteoarthritis or wear and tear of joints is not a wear and tear disease like everybody will tell you. And it's the same thing that you're addressing with all these other processes that you're talking about. How do we protect the brain? How do we protect our hearts? How do we protect our muscles? This is all systemic processes that we have to get under control. And that some of us are genetically inclined, unfortunately, that when we have an injury, that it will stir off this inflammatory cascade that doesn't shut off normally. It sort of stays up. So in perfect health, perfect case, everything's good. You've got perfect genetics. You're eating perfectly. Your health is perfect. You're exercising perfectly. You hurt yourself. And we see this cascade of inflammation, right? That's supposed to happen. But that should last a few days. And then your body comes in and starts promoting anti-inflammatory things. What we know is in people who have injuries, a lot of times, instead of that anti-inflammatory stage happening, the inflammatory stage just stays. And it stays and it stays and it stays. And that's what progresses these joints after an injury into developing osteoarthritis and then progressive osteoarthritis. And it's why really, and such a controversial topic, because even in the functional medicine world, I see my colleagues not really paying attention to joints, right? They're like, well, you should just go see the orthopedist about your joints and they'll address everything else. This is a systemic issue. Let's get you healthy, but they won't really look at joints that way. And, and so I think we have to really start teaching that this is a pathologic process. Even when all factors are equated for, like age and exercise level and diet and whether you're a smoker or not, if you have osteoarthritis, you have a 5-time higher likelihood of cardiovascular disease. So we know that this is a systemic disease process going on. And it's why if you replace a hip, all is not well, right? Sometimes you need to replace a hip. It's just too far gone. But what happens next? That person 2 years now needs their next hip replaced, and year after that needs their knee replaced, right? Because we have not treated the systemic disease process. So that's really been one of my goals, is because I'm coming from this from such a weird world of orthopedics to functional medicine or health-focused medicine. It's not what orthopedic doctors want to hear. There's a whole lot of money in replacing a hip. So the fact that you can avoid it is not really a well-liked thought among the medical community. And it's very funny. I actually left my old practice because, I was trying to kind of really actually treat people well. And I would get labs on them and do all this stuff. And I'd been in that practice, almost 30 years. And my younger partners came to me and they said, listen, why are you getting labs on patients? I said, well, because that is really how you can figure out if you can get people better. They said, we don't do medicine here. We do orthopedics. At that point, I thought, you know what, this is not working.
Well, Dr. Yurth, that begs the question, if the first line should not be to replace these or necessarily even do some invasive procedure, what is your approach to get the body out of that inflammatory state and into a state where it can heal and regenerate?
So we now have a pretty good handle on what's going on in osteoarthritis. And just like rheumatoid arthritis has elevations in certain inflammatory proteins, what we call cytokines, so does osteoarthritis. They're just different. And what we found is that in people who have osteoarthritis, or sometimes even after a joint injury before it's progressed to osteoarthritis, have very high levels of a couple of things. One is something called interleukin-1 beta. So this is one of the inflammatory cytokines that's also associated with other diseases, including cardiac disease. So they have much higher levels of interleukin-1 beta, both in the joint, but also systemically. They also have higher levels of tumor necrosis factor alpha, which is elevated in almost all bad disease, right? So tumor necrosis factor alpha is elevated in other inflammatory disease processes, rheumatoid arthritis, things like that. So it's another inflammatory cytokine. But they also have super elevated levels of some of these what we call degradative enzymes. One called MMP3 and one called ADAM. Those enzymes, they're like the cleanup crew. So let's say there was a murder in your house, right? And you now had to have somebody come scrub everything down, right? And get rid of all the mess. So let's say you hurt your joint and these guys got to come in. They're like, okay, there's a lot of trash here. We got to clean it up. Well, that's fine. What if they keep cleaning? So now these guys in your house keep scrubbing your floor, right? They're like scrubbing and scrubbing and scrubbing. And what happens? Now there's no floor. So it's exactly what happens is you see these elevations of these enzymes, MMP3, ADAM, these degradative enzymes, and they just stay up. So now they've cleaned up some of the trash that's gone on, like you tore your meniscus, but they've also started to clean up the meniscus itself and the underlying bone underneath, which is why we'll see bony edema and things like that in these patients. So we realized we had to do a few things. We had to block interleukin-1 beta. We had to block these degradative enzymes. So there's a few ways of doing that. One is if somebody has like a very acute injury, so even if I'll send them to surgery to fix the injury, I'll sometimes follow that with injecting the joint with something called alpha-2 macroglobulin, or A2M. So A2M is this little protein that you have floating around that actually is your rescue. So it's there to now say, oh, too much cleanup, let's get rid of you guys. So it floats around. This is everywhere in your body. It's, a heart attack, it's going to be there. If you hurt your joint, it's going to be there. If you have a wound, it's going to be there. A2M says, okay, guys, time to turn off. Let's get rid of the cleanup crew. So this little molecule, which almost looks like a little Pac-Man, comes in, it binds off these degradative enzymes and this interleukin-1 beta, and it gets rid of them back into your circulation and eliminates them. But a lot of us have lower levels of alpha-2 macroglobulin, or we just don't have as good circulation as some places, like our spine, for instance, or certain joints just don't have as good a vascular flow. So the A2M can't really get there very well. So you can actually take it out of the blood. So we basically take a bunch of blood from somebody, and we have a filter that can filter out this size of protein. So it's the exact size of protein. It takes about an hour to filter out this protein, and you very carefully siphon it off. So you basically filter off this little protein, and then you take it and you inject it back into that joint. And it turns off the inflammatory cascade. So people can now initiate a healing process. And the company who makes the A2M, who has studied A2M the most, called Cytokines, actually did some research where they actually had, at one of the universities, they did where somebody had an injury, like an ACL reconstruction. They would inject A2M right at the time of surgery, and these people fared so much better. They healed faster. They didn't go on to develop progressive restrictions in motion and things like that. So we know that A2M is a big player there. So that's something you can kind of do acutely. But what about your people who have like kind of now arthritis all over? It's not so chronic. It's more chronic stage now, right? Now they potentially have arthritis in a lot of places. Both their knees are kind of bad, and there's not really an acute injury. So how do we systemically lower these bad things? There's a very cool drug that hasn't made it to the US yet. It's in phase 3 trials here, so hopefully it'll be available in about another 3 years. remember, it takes a really long time for things to get through the FDA in the US. So one of our goals, I belong to this sort of research faculty group that we actually look for things that have been proven safe and efficacious in other places, and then we try and figure out how can we get them. So this drug xylitol has been being used since it got approved in Australia in 2019, and it basically was considered a cure for osteoarthritis. It worked that well. It had significant improvement in pain. Like 80% of people had dramatic improvement in pain. And the year-long follow-up, people had improved cartilage height in their knee by about 25% and disc height, whereas the placebo group had lost cartilage height. So this drug, xylitol, which generic is called Pentosan Polysulfate, is available here in the US, but it's available as an oral medication used for bladder inflammation. It's called Elmiron. So the drug is already approved here. It's just not approved for this purpose. The problem with the oral drug is twofold. Number one, you need to dose it quite high for the bladder inflammation. And at a high dose over a long period of time, it was associated with some eye problems, some damage to the retina. And the other problem was it just didn't seem to be particularly effective for joints when it was ingested. It was great for bladder inflammation. It's actually great for a lot of things. It's great for gut. It's great for bladder inflammation. It's great anti-cancer agent. It's great for heart. But it wasn't so great for joints. What they found, however, was by injecting it, just not even into the joint, but subcutaneously, a couple of times a week, did really well for joint health. So basically, because the drug was available in the US, we could have a compounding pharmacy make it for us into a injectable drug. And we can have people just self-inject. We teach them how to do it twice a week. And they can maintain that for, I've been on this drug for 3 years. And I can tell you my knees, which are end-stage arthritis, I have, bone-on-bone arthritis, don't hurt me at all. And I went from, needing knee braces to do any kind of hiking or skiing or anything like that to being able to do pretty much everything without pain anymore. And that's after 3 years on the drug. So it seems like it just keeps getting better and better and better. Now, if we go off the drug, will things go back to where they were? It depends on the person. I don't have the greatest arthritis genetics. If I look at my dad, he had horrible knee arthritis. I know that when I'm off this drug for a while, I start to get a little bit of achiness again. So I probably am somebody who was always just making too much of these inflammatory cytokines, too much interleukin-1 beta, too many of these degradative enzymes. So I just stay on this. Its safety profile is excellent. It's been around as a drug since the 1980s. So it's been around a long time. So it actually has a pretty long safety profile. It's been around 3 years in Australia. So its safety profile actually looks really good as long as you don't dose it at a very high dose for an extended period of time. The dose we need for joints is minuscule. So it would take about 80 years of using this drug on a regular basis for 80 years before you would ever reach the doses that were equated with any of the eye stuff. And maybe we'll need it that long, but we also don't know that the systemic injection form has the same effects on retinas. This drug actually has been used in the veterinary population for horses. Horses get all the good stuff first, racehorses, and for quite some time. So they went back and looked at racehorses' eyes and saw none of this. So basically, we have a pretty long safety profile on this drug. The cool thing about Pentosan, though, Nick, is that there's now studies showing it as an incredible antiviral agent, as an incredible anti-cancer agent, reverses atherosclerosis, because all those diseases are linked to some of these same issues, high interleukin beta, high degradative enzymes. So now we actually had our compounding pharmacist make it into a little oral pill form for other issues, for gut, for antiviral prevention. It was a better antiviral than almost any antiviral out there, including our most recent virus. And the interesting thing is that you could do a tiny little, whereas the Elmiron is 500 milligrams, at a 25 milligram dose, it showed all the benefits, perhaps maybe not as much for the bladder inflammation. So for my patients who I'm treating systemic things, I will just use a small oral dose on them to treat for viruses and cancers and gut stuff and things like that. For my arthritis patients, I have them do it as an injection twice a week. And our patients get pretty proficient at it, and they feel, and I will tell you that 80% of people get significant improvement, not minuscule. And it's not just pain relief, right? We know we are regrowing cartilage. And then all of your listeners are really familiar with peptides, because peptides will go a long way there too, in terms of aiding healing. We have what we kind of consider the Wolverine peptide group, which is BPC.
I want to get into the peptides in 1 second, but one thing I want to underscore you just said that I think is really important to highlight is that not only does that protocol relieve the pain, but it also helps regrow the cartilage. Because I could take a painkiller and I could rid myself of the pain, and then I could go on nice long hikes. But I'm not doing my body any favors. The pain's there for serving a purpose. It's giving me an alert, a warning that something's not right. So the fact that it regrows cartilage is very important to me.
Right. Yeah. Remember, we're treating the cause of the pain, right? We're not just blocking pain reception, or pain perception. We're actually eliminating the cause, which is these very high levels of these inflammatory cytokines. And that's why it's so important to treat osteoarthritis systemically too. Because remember, I gave stage you that fact that do not ignore the fact that people with bad joint pain will likely have cardiovascular disease as they age. Don't ignore that. They have higher risk of cancer, independent of the fact that they might not be exercising, things like that. It's completely independent of that. So you have to think of this as a systemic disease. So not only is it imperative to, it's great, we're regrowing cartilage and we're helping pain, that's all great, right? But we also need to address the fact that there's something wrong with people who have arthritis, and we have to address that, or the other consequences are going to happen. That's why joint replacement is, sometimes, I have patients who are too far gone. A joint replacement is going to be amazing for them, right? Their hip is trashed and their life is changed by joint replacement. But I'm not going to say, okay, you're cured now, right? That was, yes, we're fixing the fact that your joint was completely trash. We can give you a new joint. You're going to destroy all your other joints. You're going to still have cardiovascular disease unless we treat the systemic cause in the first place. So we have to go back to thinking like this, like you do every other disease, right? The worst thing we do to people with arthritis, so in every other country, people over the age of 30 are not allowed to have a knee arthroscopy. It is a number one bread and butter surgery here. Because when you go in there and scope the knee, what do? You're stirring up all this inflammation. But here's what happens. Somebody goes in with a knee pain. The doc goes, oh, your meniscus is a little damaged. We'll just go trim that up and clean the joint up a little bit and all will be well. It's equivalent of somebody with Alzheimer's coming in and go, let's just go cut out those bad pieces of your brain. It's just stupid. And people who have knee arthroscopy will get a rapidly worsening progression of their arthritis a year or so after that, even if they temporarily feel better. It's a really bad surgery for people to do. And yet it's the number one orthopedic surgery done here.
What do you do in that situation then? Like, what if your doctor recommends that arthroscopic surgery? Do you just push back and say, get a second or third opinion?
And the problem is your second or third opinion from the orthopedic doctor is probably going to be the same. So number one, you need to go look at the literature and look at the literature that shows, that it is not a surgery that's beneficial. And then you need to look for doctors who treat joint pain in other ways. So you need to find somebody who is well trained in this. And, there are a lot of people, I think, doing regenerative approaches using things like stem cells and platelets and exosomes and things like that. The problem is, hand in hand with that, you also have to treat the systemic problem. I do a lot of regenerative therapies. I do platelet fibrin matrix mixed with exosomes. I do all sorts of cool stuff for regenerative therapies. If I do not address the systemic problem at the same time, those people aren't going to get better. They'll just temporarily feel better, and that's it.
Yeah, and the systemic issue that you're referring to is the inflammation.
It's the high levels of these very specific inflammatory cytokines and these bad enzymes. So it's not just these inflammatory cytokines, it's these degradative enzymes. So these degradative enzymes are equally the problem. MMP3 is a bad enzyme. And when it's elevated, it creates all sorts of problems.
Are there like budget-friendly ways of addressing both of those? I mean, the protocol you mentioned a minute ago, I think that might work. But are there other things people can do? Because like you mentioned, a lot of the cool regenerative therapies like PRP and exosomes and V cells and all those things are awesome, but they're also very expensive.
Right. I think that's where Pentosan comes in as a pretty cost-effective solution. It's much less expensive than doing those regenerative therapies. Yes, it's going to be ongoing, but it's not a horribly expensive drug. It may cost you a couple $100 a month, but so ongoing. But it really, and I have a lot of patients who don't need to do it forever. Like we'll put them on it for 6 months. Like I'm doing well, and I'll take them off for a while, and then if their pain starts to increase a little bit, we'll go back on it. So it's not something necessarily that somebody has to do forever. For me, it works better. I just stay on it because I feel better on it, and just the nature of my disease is bad enough that I need it, but not everybody does. So I think that's a really, really useful option, because even when you're talking about things like, yes, exosomes and peptides, they're pricey and they're harder and harder to get, right? It will get FDA approval. I'm not sure when, then I don't know what insurance will do with it. They're going after just knee osteoarthritis. So insurance will likely start paying for knee osteoarthritis at some point when it passes FDA approval. And it will. They're fast tracking it through. There's no reason it won't. So it will get FDA approval. And and then the question is, will insurance actually cover it or not? As all of these insurance-based things are, will it just get more expensive? Just like Ozempic and semaglutide, Mounjaro, those drugs. Then everybody just jacks the price up. Nobody can get it, even though insurance pays for it. But I think it will be more accessible to people as a drug comes more to the forefront. If you guys just Google xylitol, made by Paradigm Pharmaceuticals, it is really a compelling drug.
You were also the first person I saw to talk about FG loop peptide, and that is, I'm sure, along the big list of peptides that you're interested in and or using in practice.
So FG loop peptide is really good for brain function. So it's really helpful for brain. It got a little bit pushed to the wayside with some of the other peptides like C-Lank and C-Max, which are a little easier accessible, a little less expensive, and not injections. They're nasal sprays, so that's nice. FG loop peptide, it got sort of pushed by the wayside. I think we'll see it make a little bit of a comeback because it's not on the FDA list of peptides we're not supposed to use anymore. So I think we'll actually see FG loop. We sort of looked at it as a substitute for some of our nootropics that we all might have less access to. But it is a very interesting peptide in terms of treating really brain disorders, especially things like cognitive decline, Alzheimer's, and Parkinson's. But really, as a nootropic peptide as well, it can be very useful. Again, a little harder to access, but and a little bit pricier than some of the things like C-Lank and C-Max. I think from a perspective, if I'm going to use a nootropic, I still like C-Lank and C-Max a little bit better, which are our nasal spray nootropics from Russia. I think they still, for the like people like you who are just trying to sharpen their brain, I still think they have a little bit more of a dramatic effect. But I will say that I've reserved FG loop peptide a little bit more for my cognitively challenged people. And I haven't used it as much in my super healthy group people. And I'm starting to use it a little bit more again. So I think I may, that's one of those things where you sort of have to trial and error things in different dosing and use it long enough to sort of get a sense, am I going to like it as well or not as we get back into using it? When it first kind of came into favor, we sort of used it a lot, and then it got sort of pushed by the wayside. I think we'll see a comeback of it a little bit now.
With regulations around peptides changing, it's frustrating that a lot of the great ones are now being banned or at least put on hold in terms of the ability to acquire them above board. And I know that C-Max and C-Lank were big ones. I really like those, and it's a bummer to see those go. And also for your work, I'm sure that BPC 157 and TB 500 and a bunch of the others are going to be a bit harder to procure now.
Yeah, the good thing about BPC and TB4 is that they can be taken orally, and they do work not quite as well as systemically when they're done as an injection near the site of injury, but they will still be available orally. So it's orally because they can be considered a nutraceutical given orally. So basically they can get by the FDA. So we'll still have access to those too. I think you have to dose it a little bit higher, and probably it's not going to be quite as good for like acute injuries, things like that. But at least we'll still have access to those. And even for most of those peptides on the list, there are other good alternatives. When you look at things like CJC and ipamorelin, which also are mainstay treatments for things like growth hormone deficiencies, those are great. Is there options? Yes, there's sermorelin, there's tesamorelin, there's still things that are on that list or off that list that we can use. So we have a lot of workarounds for things, so I think we were a little less devastated when we sort of thought through our world a little bit. I think it's one of those things where you have these things that are always that you just standardly use, and there's a lot of other good options out there. So, number one, we're continuing our battle against the FDA on this. We're actually working with an attorney who's won against the FDA about 8 times. And you guys who are listening, just go to savepeptides.org, sign the petition there, put your stories in, because that's going to help us to go from a political realm to kind of continue to fight this battle, because peptides really are incredibly beneficial for healing and recovery and helping people with diseases that nothing else treats, like mitochondrial diseases and things like that, and all of our long COVIDers and long COVID injuries.
Yeah, clearly we're both fans of peptides here. And from your descriptions and the fact that you have an attorney helping to hopefully get them deregulated, that makes a compelling case for your desire to incorporate them and keep them incorporated in your practice. Can you describe how it is that you use them, whether it's the ones that have been semi-banned like BPC or it's TA or any of the other ones?
You always talk about bioharmony, which I love that word, as opposed to biohackers, because honestly, our bodies are really, really good at being well. They really are. We do a whole lot to F them up, but they're pretty good at being well. And the really cool thing about peptides is they're super homeostatic, right? Our body makes most of these peptides. And so they're actually are treating the body to help itself get well instead of saying, oh, I'm going to just throw a whole bunch of this one supplement in and that should get rid of all my oxidative stress. We want things that are more balanced or homeostatic, right? And that's where peptides are so, so beneficial. It's because they really don't, it's not like, these people who are saying, okay, I heard resveratrol is the best thing. I'm just taking massive amounts of resveratrol. And, you need oxidative stress. If you block all your oxidative stress, you've done a bad thing. There's this very delicate balance in the cell. And when you screw it up, that's why I tell my patients, I don't leave them on any kind of course of supplements, sort of a few basics on a regular basis. I cycle them through. So peptides allow us to actually work in a much more homeostatic, balanced fashion. We're not screwing up one pathway at the expense of another. And so that's really why I love them. And I will lots of times from just an overall performance longevity state, I will cycle through groups addressing different things that happen to us, right, as we age. So if you look at things that decline as we age, one of them is mitochondrial function. So if I need to get mitochondrial healthier, what do? Well, lots of things you can do, right? Eat right, sleep better, do cryo, do sauna. But some people are still challenged, exercise. So let's say I have somebody who's so done that I'm trying to get them to exercise and they literally, they walk 10 feet and they're exhausted, right? So what do I do with those people? Well, that's where things like MOD-SC, which is a mitochondrial peptide. Remember what happens when we exercise is we stress our mitochondria and we cause more mitochondria to form. The body's like, oh, need more mitochondria. But what if I can't stress to that point? Or I've lost so many mitochondria at this point from viruses or diseases or states or just aging, right? I've lost so many mitochondria. So my belief is replace the things that we lose. So we're losing mitochondria. Let's a few times a year, 3-4 times a year, let's give a little course of MOD-SC. Let's replace those mitochondria. And I may do that more acutely if somebody's coming to me with obvious mitochondrial damage, but even in myself where, I'm just getting old is to basically replace 4 times a year. I go through a mitochondrial protocol for 6 weeks. So I'm replacing mitochondria. What else happens? We actually lose our thymus gland. So our thymus gland, when we're babies, huge gland sits in our chest. You do an x-ray of a baby's chest, massive thing. Looks like a huge tumor in their chest. When we hit puberty, our thymus gland starts shrinking. So by the time you're my age, it's a little fatty nub that's not doing anything. But the thymus gland is really important. And the body sort of thinks, the reason the thymus gland sort of shrinks down is because the body thinks, okay, after puberty, I don't really need all this stuff anymore. I've trained the immune system, all's good, without really the understanding that, number one, we're going to live this long or be exposed to all these stresses. So the really sort of crazy biohackers are trying to transplant thymus glands, right? They're trying to get thymus glands from babies and transplant them themselves. They're eating sweetbreads to eat thymus glands. Well, let's just give back the peptides the thymus gland makes. So you want to course through courses of thymosin alpha-1, thymosin beta-4 to try and replace the thymic peptides. So basically, now going through a cycle, 6 weeks, I'm going to make sure I'm replacing the thymic peptides. And then BPC, which is another body protective compound, which is made by our gut, which is another peptide that declines as we age. So remember, these are all things that we make naturally, but they get lower as we age. So if you're going to say, I'm going to replace things like hormones as we age, why shouldn't we replace the peptides as we age too? So then I'll cycle people through using a combination of BPC, thymosin beta-4, thymosin alpha-1. So, maybe a 6-week cycle of mitochondria. Then I'm going to do a 6-week cycle that I'm going to really focus on immune function and thymic function. And that's going to be that course, right? Then you look at growth hormone. There's always sort of there's this battle between the IGF high, IGF low people, right? We know that low IGF people live a really long time, but they are pretty frail and not really how I want to live. They have no muscle mass, they break bones. There's a whole tribe that has very low IGF and they live a long time. They don't get cancer, they live a really long time, but they're super frail and they can't do much and they have poor cognitive function as they age. So this has to be a balance there, right? So I do think also replacing growth hormone, and we use peptides like CJC, ipamorelin, which are going to be less available, but now sormorelin, tesamorelin. And again, you can cycle those too, right? So we're kind of going through highs of IGF and lower IGF. Our bodies are always designed to be this up, down, right? That's that homeostasis. So then I'll cycle courses we're all trying to balance out the growth hormone levels. So now I'm kind of thinking, I always sort of work my patients kind of seasonally. That sort of, you're going to be your mitochondrial cycle, your immune function with thymus function. Let's get your pituitary function with growth hormone. And then twice a year, I have them hit with the pineal gland's another gland that goes away as we age. So pineal gland's your big circadian rhythm detector, right? So one of the things that happens as we age is the pineal gland calcifies. And it doesn't regulate light dark cycles very well. So even if you have somebody perfect, they're in the light all day long, they're working outside, and then they go to their dark house at night, and they're living out and camping all night long. Great. Do they still stay normal as they age? No, because the pineal gland isn't there to actually interpret those messages very well. So what I'll do, and that's why old people, when you look at them, lots of times their circadian rhythms are really off, right? They don't sleep well at night. They fall asleep during the day. Their circadian rhythms are off. So we'll do things that do a circadian rhythm reset. And epitalin, for instance, pineal function, and you'll do like a high dose, 10 milligrams, 10-day kind of dose of epitalin or Epitalon, however you want to say it, to basically replace pineal function. So where I come from when I'm looking at these peptides is, what's the body losing? How do I give back what the body does? And cycling that. I'm a big believer in always cycling things through to keep homeostasis. Now, I will use peptides acutely as well. So, for instance, I tore my rotator cuff completely about 2 months ago and had to have it all reconstructed. So, am I every day injecting BPC TB4 into it? Yes. So I'm going to be using this acutely if there's an acute injury as well. Or let's say you just got out of the hospital or you just had COVID, you're going to hit mitochondrial function really hard right then. So there's going to be times you're going to use these more acutely as well, right? Or based on what we're seeing on laboratory function. But if my perfectly healthy performance people where I want to just keep them alive to 120, I'm still going to be cycling those peptides on a kind of regular basis. And again, there is options, even with some of the loss of some of those peptides, there is options in each of those realms. So there is something to substitute for every one of those peptides I talked about.
Yeah, when I would travel, I used to bring some LL37 and some TA1 with me, and I kept that in my bag. And if I ever felt the slightest bit of anything coming down with anything, then I'd start those, and I would never get hit with the full whatever it was.
Yeah. LL37 is one of the antimicrobial peptides, and it's what's called a cathelicidin, and it's preserved across every species. Even one-cell organisms have LL37, so we know it's really critical to life, and it really is able to fight off infections. Even if you have, a resistant bacterial infection, LL37 can help treat that.
Okay, so we have some information about peptides now, a little bit about sports and injury. What about like on the prevention side? Like, what do you do? Do you have any protocols or practices you like to prevent injuries from happening in the first place? Because I know that I had certain friends growing up that were magnets for injuries. It seems like they would always be getting a different injury of some sort, 10, 20 by the time we even graduated high school. And then we had others that never got injured. And so there's like a huge difference. And I don't think it was just genetic.
Yeah, I think genetics do play a role there. I think there's differences in collagen, function, and so I do think genetics do play a role in that injury stuff. But what else plays a role? Obviously, the kind of exercise training you're doing. So I think lots of times we become very sports specific to our training, and that ignores certain things. You've got to always be making sure you're including balance training, flexibility training, all those pieces. When I look at a lot of our athletes now, the flexibility training is not there. I think everybody should be doing yoga or something in terms of the flexibility and balance realm, because I think we're not training, even especially our younger athletes, right, in that realm. They just go to the gym and lift heavy weights. That said, I also think you need to lift heavy weights because that's also a hugely important piece. Exercise. If you can have one pill that cures everything, it's exercise. And if you want to bias which exercise, it's strength training over cardiovascular training. Both are important. Strength training is more important. So I think you have to strength train. But I really think, from my own experience as somebody who would be one of those, injury magnet people, having torn my ACLs recently, tearing my rotator cuff, and you would think at this point I would have learned this, but I haven't, is that recovery is as critically important as the exercise itself. There's this little conversation that we have to listen to in our brain. And you can use your tools, you can use your Oura rings and things like that. It says, okay, don't work out today, take it easy today. Those things I think are helpful, but a lot of it is literally, honestly, just knowing that recovery is equally important to the exercise. And I do think we all sort of, all of the people in this kind of biohacker world are a little bit obsessive, right? And probably where we fail ourselves a little bit is getting too obsessive with things, exercise being one of them. But I will say that when you look at collagen function, I used to be a dancer, and so I used to treat a lot of dancers, and and every dancer has dysfunctional collagen. The only way you are that flexible is to have dysfunctional collagen. So those people need higher doses of vitamin C. They need higher doses. They need collagen mixed with vitamin C. They need to actually be addressing that. I was giving this little lecture to these dancers, and all of them are sitting there with their straddled out legs or leg behind their head and things like that. They're just unduly flexible, which is great for dance, but it also sets you up more for injury to ligaments and things. So, and there are multiple different disorders. When you look at the collagen, there are multiple different disorders that make the ligaments and tendons a little dysfunctional. There's also a big play to hormones here, right? So like in that young age when you're in high school and you've got these kind of hormones kicking in at these weird, sometimes super, I have 5 kids. My youngest is 17, and he's always at that age where sort of testosterone is really just starting to kick up a little bit. And he's super tall and gangly, and muscles haven't caught up yet. But his testosterone is really kicking in, right? And yet, when you look at those kids, there's not the stabilization between the testosterone and estrogen levels being stabilized yet. And when you have some, it's like my bodybuilders who do a squat and both their patellar tendons ruptured. If there's too much testosterone, not enough estrogen, then you will snap a tendon. And so I think there's a big piece to hormones there as well, and what's going on with hormones. And that really starts to factor in as we get older too, is that hormones play a big role in injuries, both in men and women.
Anything else that you'd recommend taking prophylactically, like maybe MSM or peptides, or is that overkill?
If you can afford to doing peptides on a regular basis, I think, again, cycling those peptides like BPC and thymosin beta-4 is really, really helpful to joint protection. So I think that is definitely, beneficial. I'm not sure MSM is all that helpful. I think the data is a little bit mixed on that. I do have some patients who love it and makes them feel better, but I don't know that the data is really there on it. I think some of the basics, you need D3 with K2, 10,000 IUs a day. You need magnesium. So you need those very basic things. And then if I look at sort of the more kind of out there things in terms of injuries, are you familiar with fatty 15? An omega-3. Yeah, so fatty 15, which is an omega-3, actually has some really interesting data to support it in injuries as well. Whereas omega-3 fatty acids from fish oil don't seem to have the same benefit to joint health and collagen health. Fatty 15, which is a 15-chain carbon, actually seems to be really, really critical to cartilage and collagen formation. And so they've done some really interesting studies looking at these 15-chain carbons as a very important piece. So I have all my patients now on at least one fatty 15 a day for that EPA, omega-3 EPAs. And actually, I'm using a lot less of the fish oil now and a lot more fatty 15 after the data's come out, just showing how much oxidative stress you can create sometimes with fish oil being oxidized either in the jar or in your body. So I'm using a lot more fatty 15 in that realm. The other thing is everybody should be on creatine. Creatine is both skeletal muscle protective, but also brain protective. So everybody needs 5 grams of creatine a day, especially if you're exercising a lot and working out a lot. And then you've probably read about taurine now, which is kind of coming in as one of the newer in the anti-aging realm. And I'm pretty compelled by the data in it and joint health as well. So I think taurine, I've sort of started adding that to my regimen as 2 grams of taurine a day. I think the data is pretty compelling on taurine. It at least really does seem to modify some of the, it's one of those more homeostatic agents in monitoring oxidative stress. So if you're taking your omega-3 fish oils, if you're taking fish oil as fish oil, then you should be taking taurine with it to try and avoid its oxidation, because oxidized fish oil is more bad than good.
Yeah, that's actually one of the ingredients that I use in my evening drink I make. I'll use glycine, I'll use some magnesium glycinate powder. I
Uh-huh.
don't love the taste of glycinate powder, but I'll use it for magnesium. I'll use, taurine, glycine, magnesium, a little bit of potassium, and a couple other things. And I find that it's a very nice, mellow evening wind
Yeah,
down. Like,
that's a great combination. Yeah.
yeah, increasing GABA levels gently without anything too
Right,
potent.
right. Yeah, without him being hungover the next day.
Yeah,
So,
yeah,
yeah.
exactly. So, what are some of the other molecules and things in the longevity sector? Since Boulder Longevity Institute's one of the big names, I'm sure you're up to date on all of the stuff going on and the things that are most important to keep our eyes on.
Well, I think so much of it still comes down to basic, but I will tell you, this big sort of focus now we have on NAD, and we all know NAD is critical, right? We know that levels decline as we get older. We know that it's an absolutely critical molecule for ATP production, but I think we're doing it the wrong way. And so we've been doing a lot of research on this because the problem with NAD, number one, people are doing things like NAD infusions. And for those of you who are doing them, that's your business. I'm not, maybe everything I'm saying is wrong, but we know NAD itself can't get into the cell. And, so there's no receptor for NAD in the cell. So you really are getting maybe some helpful. Mostly it goes to the liver and maybe gets a little bit of production up, but it's really not worth massive amounts of money. So the precursors like NR and NMN, why are they good or bad? Well, number one, they can get into cells, so that's good. They actually get into the mitochondria where they're beneficial. But the reason our NAD levels decline is not really that we make less NAD. They did a great study with what's called a CD38 knockout mouse, where when they got rid of the degradative enzyme for NAD, mouse NAD levels were fine. So it's not that we really drop making NAD. It's that we increase the enzymes that are degrading NAD. So basically, now you're filling the bucket, you're taking your NMN and NR, but if you haven't blocked the degrading enzymes, and there's a few of them, there's CD38, there's NMNT, and then down the road, there's something called NNMT. So basically, you're filling this bucket, right? There's a hole in the bucket, and now that hole is sort of just draining all this water out onto your floor and ruining your wood floor. So people are doing all this. So if you're taking NMN or NR, you've got to block these enzymes. So you have to use a CD38 blocker like epigenin, and that probably helps. But you also have to remember that we have no idea when the bucket is full. So remember we talked about that whole redox balance. You have to have a balance between reductive and oxidative stress. And because NAD is one of our biggest electron donors, if I keep feeding it in, I actually start screwing that up, and that too much energy state is not a good state either. So what the body has done to salvage that is it upregulates an enzyme. Now this enzyme, which is called NNMT, further down the chain, is really upregulated primarily in cells you don't really want to be happy. Cancer cells, senescent cells, fat cells. So when there's all this excess energy, the NNMT upregulates and it starts forming, number one, it forms 1-MNA. That's a salvage molecule, and that's actually a good molecule. So 1-methyl-nicotinic acid is a really helpful thing. But it also feeds into all these cells that are like, great, I have tons of NNMT. I'm going to steal this and make my own NAD. So if you're overfilled the bucket, you've now just fed your fat cells, your cancer cells, and your senescent cells. Not what we want to do. So really the better way is not to take even the precursors, but to take something that blocks NNMT, because that's where that drain is going down. So what we've been trying for the past 2 years to get is a molecule called 1-MNA. And it was only made by a company in Poland, and they would not sell it to the US because they wanted to bring it as a drug to the US. They wanted to bring it as a pharmaceutical to the US. They were trying to go through the pharmaceutical hoopla to get it as a pharmaceutical because it is that powerful as an anti-cancer agent, as an anti-obesity agent, as an energy agent. So they thought they could get it through as a FDA-approved drug, and they thought that'd be the better way to go. But we sort of met with them like, listen, that's stupid. It's going to take you 17 years to get there, even though you've gotten your first couple trials done. It's going to take you too long to get there. We'll help you bring this as a supplement. I promise you will do better because we have real smart people in the US. The problem is Europe is very different. People don't buy supplements except when their doctors have them. So they didn't get, I said, you got a savvy group of people here. We'll teach people. And this is a much better supplement. It's taken us 2 years, but we finally have 1-MNA across the customs where it was stuck for a very long time, and have brought it to the U.S. And a company called Longevity Launch has kind of brought it over. So what 1-MNA does, this is a really good thing. It acts like NAD, so that's a good thing in and of itself, but also blocks NNMT, so it lets the NAD stores come back up. And we've blocked all the NNMT that's going to the cancer cells and the fat cells and the senescent cells. So now we block this enzyme that's so upregulated in all those cells. So NNMT is being researched very heavily. They're looking for NNMT blockers for treating cancer. So we have this really good one here now. And, and hopefully the pharmaceutical company will be made the right choice. I think they did. So this is going to be really cool. And I think it's by far the much better way. And I think what we have to do now is retrain people that what's happening with NR and NMN. And that's going to be a little bit of a hard battle because people are very married to their NAD infusions. But I could tell you that you will feed cancer eventually if you keep throwing NMR or NR and NMN and NAD into the mix and not knowing what you're doing on the downstream pathways. So I think that's going to end up being a really big talk. We're going to have all of our patients taking it because those are the bad things we don't want to have happen is people getting fat and metabolically dyscontrolled cancer and senescent cells. So I think that molecule is going to be a really, really promising one. And then I think the other thing we're going to start seeing more of is using really IV exosomes guided to places that we want them. Like, so using transcranial ultrasound to guide. So you run IV exosomes and then you can target them to certain places. We're doing this with a machine called a stem wave for joints, where you can use an acoustic wave that very interestingly attracts stem cells. So you can run the IV exosomes, get systemic effect, but then target them to certain places, even the brain. But so transcranial ultrasound. So I think we're going to see this more guided exosome kind of therapies going on. We're sort of really targeting them to very specific places to treat these very specific diseases. I think that's going to be kind of big in the realm of the next year too. But, I think, new molecules, fatty 15, 1-MNA, super cool molecules that we need to keep an eye on. And again, you're sort of bucking, so where fatty 15 is struggling, right? They're bucking that everybody needs fish oil. Well, maybe not. Maybe we need more fatty 15, not fish oil.
It's funny. I was just talking to Dr. Chris Rhodes the other day about 1-NMA, and I was like, why don't you just use this? He's like, well, we can't use it. It doesn't exist commercially. So it's cool to hear that that problem is being solved. And then also, I just recently recorded a video on the downsides of NMN and NR and all
Good for you.
those.
Thank
and it's
you.
funny that you mentioned that up. Also, you mentioned that, and you know more about it than I do, but I just saw that as like something that people are not thinking about the
They're
potential
not thinking
consequences
about
of.
right. They're not thinking about the consequences.
Yeah, it's like higher dose, more is better.
Right, exactly. That's a very more is better thing. And more is, in general, we way do too much of that with our supplements and everything else. The more is better thing is, that's why I like your whole thing, bioharmony. The body is really designed to be in harmony. It doesn't take a whole lot to get it back. And you don't have to be throwing billions of antioxidants and billions of this. Smaller doses cycled through is the way to go.
Yeah. That reminds me, do you use or are you at all interested in bioregulators?
So I do use bioregulators. I was a little reluctant to jump on the bioregulator bandwagon, partly because all the research comes out of Cavinson's lab, right? And I was like, okay, how much do I trust the research of the guy who makes these? And now they're trying, Phil Mickens with Profound Health is trying to kind of more legitimize them, working with Dr. Campbell. And even that data I'm a little bit suspicious of, just because the way he's conducting that study is a little bit skewed. So I'm not 100% convinced. I wish I had more data, but I'm willing a little bit now. I'm experimenting with them because I think they make sense. I just would like to have more. I'm very scientifically minded, and I really would like to have more independent data on them. So I'm kind of doing my own little stuff with them now with patients, just following things I'm working on to see if I'm getting progress on them or not. Access has been pretty tough on the bioregulators too, because of they come from Russia. So that's been a little difficult. So Profound Health has been out for a while. So those have been a little bit harder to access. But I do think the bioregulators probably do have a place.
Yeah, I haven't had to use them yet. I like the idea of them and I've been looking into them. And every time I go to pick up them and actually test them myself, they're out of stock. So I can't actually do it anyway. Or I can find like these sketchy websites that
Right,
I've
that have
never
them, I
heard
know, and
of.
you're like, how are they getting them when the main guy who can't get them? I'm always like,
Yeah, I'm like, I'm not going to take my chances with whatever's in these capsules. But I like the theory of them. It sounds
I did too. I
promising.
mean, when you look at that more kind of bioharmony thing, right? They're working at a very base level to kind of sort of help re-regulate things. They make sense. And Cavinson's got some very compelling data. It's all Cavinson's data out of Russia. I just don't know how much to believe.
I forget the doctor who's trying to recreate that here. I think it's Dr. Bill Rollins or something, but he's
Bill Campbell.
Bill Campbell. Okay, yeah,
Yeah.
he's trying to run something here,
Yeah,
and
so that's what I say. His study is so what he's doing is he's basically using, because you have to buy the bioregulators, which are expensive, and he's doing these cycle bioregulators and then using true age tests on them to see that their true age numbers are decreasing. all the people who are doing it are pretty much very high end people who are doing a whole lot of other things as well. But because you have to buy these and it's ending up, it's expensive, it's expensive realm. So most of the people I know who are in it are either doctors. So he's tagged a lot of physicians into it. So it's a pretty skewed population that you're using it in. Um, and I just saw an interesting uh, study on the True Age test, where doing it 5 days in a row varied the true age by about 5 years. Like from one day to the next, it was like 5 years difference, and then 3 years difference, and then 6 years difference, and then so I'm not sure that very like little things that we're doing the day before the test aren't very much, because your DNA fluctuations could be very, very, very volatile. And so I'm not sure that, and the multi-omics test that they're doing now is better, but even that, I'm not absolutely convinced that that data is giving us all the information it should. It's probably the best we have, but I'm not sure it's everything we need.
Yeah, Dr. Yurth, that's my issue with a lot of the lab testing in general, like blood work. You check your testosterone after one night of really bad sleep. It can,
Or how much you exercise, what you ate, right. I have that conversation with my patients all the time. Like, this one guy whose his testosterone was obviously low. And then, so I got him on testosterone, and then one test it looked good. And then his doctor did another test, and it looked horrible. It's like, oh, the testosterone's not doing anything for you. You should stop it. I'm like, what time of day did you go? What did you eat? What did you exercise? It is hard. It's hard. If you exercise a lot, your creatinine level will look high, and so people will say, oh, your kidneys are failing you.
you'd think that someone would ask me if I'd exexercised that morning or the night before or
Right, or how
something.
much
Nope.
protein you ate. Nope, nope.
Yeah,
We'll just tell
none
you,
of that.
proteins are not good. Stop eating protein.
What about your approach? If someone came to you in their, say, 20s or early 30s and wanted some guidance on longevity, what they should look into and research, where would you point them versus someone who's in their, like, say, 70s or 80s?
I will tell you, I'm a big. Everybody who works with me in my office is young, and we're really trying to push this work. Because honestly, I wish I'd known when I was 20 what I know now, right? But the you know the whole key is the earlier you can start this journey, the better off you're going to be. The less accumulation of damage you have, the less you're trying to reverse. If you look at the studies on rapamycin, for instance, the studies were very compelling. You should start rapamycin in your 20s, at least by 30, right? Much younger than we would thought. But if you look at the animal studies, mice did much better when it was started earlier rather than later. So can we prevent that damage, that senescent cell damage burden? Because it starts accumulating in your 20s, start getting more senescent cell damage. So probably I think by 30, you should start thinking about something that's actually getting rid of senescent cells. I actually think rapamycin is a very valuable tool because, well tolerated. It doesn't cause a lot of side effects. So I think that's important. I also think that we need to be really get these people looking at hormones at a much younger age too, because we see so much hormone dysfunction. And it might not be that everybody needs to be put on hormones, right? But they may need things to try and modify that, at least to be aware of it, right? So using things like kisspeptin or enclomiphene or things like that on young guys who have these low testosterone, because we're seeing really low testosterone in the 20s, and that doesn't bode well for your future. And we're seeing a lot of, women's progesterone levels start dropping mid 20s. That's why it gets harder and harder to get pregnant as you get beyond 30. So, when we look at hormones, I would say you need to know hormones earlier. You also need to know how you're metabolizing hormones at a young age, because that's the key to whether you're going to get cancers or not, right? So we sort of recommend young people get a Dutch test, this dried urine test of complete hormones, which looks at how the hormones are metabolizing in your body. So if you're a male and you have a lot of hormone going into 4-hydroxyestrone, you're likely going to develop prostate cancer with time, or a woman breast cancer. So I want people to know how their metabolism is working. I think people should know their methylation genetics. I think they should know their MTHFR gene. So I think at a young age, you should know that, because you should modify. It's a huge, huge problem. And, so if you have a defected methylation gene, you're going to really need to focus on, how can I up my methylation? I need more B vitamins. I need more creatine. I need more choline. So I think that's really important to start knowing these things and early on, as well as cardiovascular stuff. And I don't give a crap about what your cholesterol is, but I do give a crap about what your, we know that cholesterol between 200 and 250 is optimal, but, what is your ApoB is, and what is your ApoBA ratio? And do you have high myeloperoxidase? And do you have high LP little a? Because those are things that are going to kill you. And you should know that early, because that cardiovascular disease is starting in your 20s, not your 50s when you're symptomatic from it. So I think people do need testing at a young age. They need to be aware of what's going to get them, and how can we start intervening early on those processes.
Mhm. But you've mentioned genetic or genes multiple times throughout this interview. What's your relationship with that? Do you use any genetic testing? And analysis in your practice?
So we have, and we've, we went through a really big, like when everybody did with the whole big, everybody was getting tested, either had their 23andMe's or, we used Illumina for a while to get full genome sequencing on there. And I think it's useful and not useful because the whole epigenetics is so changed that, like everybody who, I have patients who I've been in my practice now for 17 years and, they've forgotten everything I told them about their genetics, right? Well, and we'll go refresh it. And, honestly, I, I think it's hard because really it's more that metabolomic profile. So remember your genetics, go to your epigenetics, go to your your proteomics, and then your metabolomics. So for a while we switched over. We're just looking at proteomics. We're using SomaLogic, and we're looking at proteomics. And now I think the big key is metabolomics. So it's one of the things I like about Nutrage's test is the multi-omics test is it looks at metabolomics. So now we can say what genes are actually expressing, what are they doing? That said, the tests I've gotten on the metabolomics, I'm like, well, I actually probably could have figured this out just by some simple lab tests. Like the things that turned out abnormal, I kind of could have predicted were going to be abnormal based on stuff. So I think there's some value in terms of, okay, am I at risk for some cancer, some weird cancers, things like that. But I think that probably looking more to there's so much variability in what happens with those genetics that it's not nearly as useful. And we were way into it. We did it on everybody. And I just didn't find it to be the bang for the buck that, especially now as I've been in practice a long time.
Well, that's good to know. It's one thing to know about the theory and the logic behind it, like why it makes sense, why it wouldn't make sense. It's another to see how it actually fares in practice. So I'm glad that you share that insight. We will start to wrap this one up for today. If people want to work with you, to follow you on socials, find your website, how do they go about all that?
So botalongevity.com. And if you're interested in seeing us about anything, you can sort of set up a consult or just ask for more information and somebody will call you. So botalongevity.com. One of our big things is like you is trying to educate people because, your doctors don't know this. You can't rely on your doctor to know this. It's hard to find doctors who know this stuff. So we're actually trying, we spend a lot of time. So we have something called Human Optimization Academy, which people can become members of. And we try and teach like we think physicians should learn just from scientific data and reviewing literature and new literature. We teach people how to read their labs themselves. And so there's a whole bunch of courses within there. And then so there's a bunch of free stuff or you can join. And then we have these cool Q&A sessions. There's a lot of physicians involved in that too. But there's people of every level. And the questions that get asked in these Q&A sessions, I have to tell you, they're mind-boggling. People are really smart and they ask me some really challenging questions. So those are really fun. We do those every month. But I try and if there's new literature, I try and go through the literature. I really try and teach people so you can make your own decisions about what's right, what's wrong. You can't really listen to Instagram influencers. You've got to be able to learn from scientific data. So that's what we try and do is sort of teach you like in a medical school kind of environment. So Human Optimization Academy, if you just go to BLI Academy, actually it's bli.academy or bliacademy.com. That's a place that you go sign up for that. It's really fun. Actually, it's really cool. And people love it. They really, we get a lot of positives on that. And then just follow me at Dr. Yurth on Instagram. I try there too, just to post little articles that I come across and critique them for you. So,
well, thanks for that. I will put links to all those in the show notes for this episode, along with everything else we've discussed so far today. And I do have a final question for you. That is, if there was a worldwide burning of the books and all knowledge on earth is lost, but you get to save the works of 3 teachers, who would you choose and why?
Well, number one, being in the medical field would be Hippocrates, because holy cow! I mean, isn't that ever amazing when you look at his quotes? It's everything we try and teach. Like what was it? Everything in excess is opposed to nature. Let food be thy medicine, and medicine be thy food. Cure often, or what is it? Cure sometimes, treat often, prevent always. So he had these really profound statements that medicine has completely lost sight of. But that, you and I try and preach that it all comes down to some very basic things, including, first off, do no harm, which we really aren't being very successful about in medicine. So I love reading his quotes. I'm always astounded when somebody puts up a quote of Hippocrates. I'm like, oh my God, was this guy so far ahead of his time? I fall very much into like the Gandhi and Buddha principles. I love this whole, Buddha's sort of teaching that, we all need to be in synergism with each other and the world around us and Earth. I think that that's a concept that we've lost sight of. So I really like that philosophy. I very much buy into that philosophy. And you look at even his metaphysical research and things like that. Again, some really compelling stuff there that will much withstand any time. From a book perspective, literature perspective, my one of my sons is the most avid reader. He has read every single book, in like he literally reads a book a day. He's amazing. But we were talking the other day about the or Huxley's book Brave New World, because if you go back and look at it, oh my God, it's incredibly, it's this utopian future where, humans are genetically bred and pharmaceutically, sort of changed. And it's exactly what's happening. And it's completely frustrating that this book was written in 1931 and we're seeing it come to, to reality today. It's terrifying because everything he sort of says in that book is going on today. And then you can see what the outcome is of it, which is not good. So I think we need to go back and look at some of this literature. I mean, 1931, and he already had this utopian future was not a good idea. And that's really what we're doing, is relying on, our government to give us the next best vaccine for something. And, what are we doing in terms of the long term of the world? We don't know.
I had no idea that book was written in the 30s. How would you like to leave people today? If there's one takeaway you want them to make sure they walk away from this episode with, what would that be?
I mean, honestly, I guess number one, just because I'm trying to preach this, is remember osteoarthritis, arthritis, joint injuries are disease states. They're not just wear and tear. That's number one. Number two is bioharmonize, homeostasis. Do not take massive amounts of a supplement continuously. You need to cycle supplements. You need to use lower doses of supplements. People are really screwing themselves up with these massive dosing of things, and you don't know what you're doing. Remember, your cells are really smart and they need a little help here and there. They don't need you to massively throw a bunch of crap into them all the time. And I have people literally come to me with 100 supplements they're taking continuously, not good and not needed. So I really want people to start thinking more homeostasis, balance, cycling.
Perfect. That is a great way to wrap this episode together today. Thank you for joining me on the Mind Body Peak Performance podcast.
Thank you, Nick. I really appreciate it.
I hope that this has been helpful for you. If you enjoyed it, subscribe and hit the thumbs up. I love knowing who's in the 1% committed to reaching their full potential. Comment 1% below so that I know who you are. For all the resources and links, meet me on my website at mindbodypeak.com. I appreciate you and look forward to connecting with you. As a reminder, the information depicted in this video is for information purposes only. Please consult your primary healthcare professional before making any lifestyle changes.